Welcome, dear friends. I'm Dr. Manjunath. Today, I have the privilege to be talking to Dr. Sharath Balaji. He's a professor and a speaker unmatched. He is the best person whom I've listened to when it comes to any case presentation, any case scenarios, any topic you give him, he will make it alive. Especially when it comes to asthma mimics, I have never seen anybody doing better than him. So, with this short introduction, I request Dr. Sharath Balaji to say a few words and then start his presentation.
Okay. Thanks, Manju. Thanks for the great introduction. Basically, it's all because of my institute where I belong to, Institute of Child Health, my Magalmadi. Everything belongs to the fame, everything belongs to my institute because the number of cases that we see in our institute makes me to come here and speak with you. And that is how I'm here. That's all. Very simple. So let me start my presentation. I'm Dr. Sharath Balaji from Institute of Child Health, Chennai, practicing in and around Anna Nagar, Chennai. The topic given to me by my dear friend Manju is asthma mimics, a topic that is very close to my heart. Indeed, basically, whenever any child comes with a constellation of symptoms such as cough, breathlessness, chest pain, or noisy breathing, invariably a pediatrician, whoever it might be, either they will try inhaler therapy or they will try antibiotics. If it doesn't work, then they will think about something else. Is this how you will see the case? Definitely, it is not so. I am going to decode in such a way that each and every, even a final year MBBS student, is not going to miss a case of asthma and is not going to start inhaler therapy unnecessarily. So let's decode asthma mimics. So it doesn't mean that each and every case of cough and breathlessness will respond to your inhaler therapy. Right. So think about this condition. You are in your clinic. You are seeing a 2-year-old boy brought by IT mother. And that child has been suffering from cough on and off for the past 1 year. The mother says there is noisy breathing, and she says that wheeze like thing. To all parents, any noisy breathing is wheezing unless otherwise proved. And the mother is asking you whether my child requires inhalers. When you wonder why, the mother herself is answering, the IT mother. Sir, my mother in law is a wheezer. Okay? My father in law is a sneezer. So, what do you mean by asthma for mother in law? Allergic rhinitis for father-in-law, and my better off is a itcher. Do not think something else. I think her better off husband must be suffering from atopic dermatitis. So there is a strong family history of atopy, and the child has been suffering from cough on and off. So the mother is asking you whether that this child would benefit from inhaler therapy. So this is one. This is what happens in my clinic often. Two, in my institute, I can have a case like this. A 10-year-old boy, cough for around 2 months duration, started on inhaler therapy, completed a course of amoxicillin, completed a course of macrolide, and for the past 10 days, the child is on ADT. And the differential diagnosis, whether it is a case of macrolide resistant pertussis or mycoplasma or drug resistant TB, or is it a case of difficult asthma or something else? So it becomes very difficult at times when you have this kind of complication, not the complication from the parent side or complication from the child side, but because of the complications arises because of unnecessary treatment and unnecessary antibiotics. Yes, there are so many conditions that can produce these, so many conditions. Your airway anomaly, your gastroesophageal reflex, mycoplasma, vascular ring, almost tracheomalacia, bronchomalacia, bronchogenesis, all can produce V's. But remember, the only V's that responds to your bronchodilator is the one which is associated with asthma, otherwise known as allergic bronchitis, or otherwise associated with ectopic cough. But how to pick up those cases in your busy OPD practice? That is what we are going to infer right now. Right. And to start with, a small poetic introduction. Every piece tells you a story. But in the choir of childhood breeds, not everyone belongs to asthma. Some are whispers of upper airway like tracheobronchomalacia, some echoes of infection. Cystic fibrosis and primary ciliary dyskinesia often presents with wet cough, bronchiectasis, along with associated allergic bronchitis or asthma-like symptoms. Some the quiet cry of a hidden anomaly, a vascular ring, a bronchogenic cyst compressing your bronchus, can manifest itself as persistent wheeze not responding to your bronchodilator. So, what we need to do to heal a child, to give a proper medication, we must learn not just to treat the V's, because not all V's are going to respond to your bronchodilators, but to listen what the V's is trying to say. V's is not the manifestation of asthma alone. V's is manifestation of so many things. Okay, so here is our chitty, and here is our first year postgraduate, and the first year postgraduate. So you are explaining each and everything to your first year postgraduate. You are explaining that not all visas are due to asthma. You are explaining to your first year postgraduate that you need to pick out the proper asthmatic V so that when you start inhaler therapy, the child will benefit. So it is very easy for Chitti to find out Vasigaran. How he found out Vasigaran? Just ask them to rotate their head. Everyone else rotated their head except Vasigaran. That is how he picked up the odd man out. That is who is the black sheep. In the same way, when your PG is asking you in the constellation of symptoms with the cough, breathlessness, and noisy breathing, how to pick up a case of asthma? Whether that cough could be due to pertussis or cough dominant asthma, cough could be due to protracted bacterial bronchitis, that stridor noisy breathing could be due to vocal cord dysfunction. Finally, the question is who is the black sheep? How to pick up a case of asthma? Remember, I am not going to deal in detail about spirometry, in detail about FOT, in detail about impulse oscillometry, because basically I am a pediatrician also practicing pulmonology in my clinic. So, literally speaking, I am not more into spirometry or FOT because we didn't have any time. So I need to rely only on certain questions. I need to rely only on certain investigations. I need to rely only on my special senses. Right now you have chat GPT. Right now you have perplexity. When you feed something, definitely you will get your diagnosis. But the God's best AI, I don't say it is artificial intelligence. The God's best AI that can be given to humankind is your special senses. What you see, what you hear, you can diagnose more compared with your chat GPT or any other artificial intelligence platforms. So please you use your special senses. Use your eyes, use your ear, use your nose, use your mouth. You would be wonder how your mouth is going to be helpful in find out that this is the answer is simple. Whenever you have a child with a recurrent wheeze not able to control with inhaler therapy, with failure to thrive, and down with the severe bronchiectasis, kiss him. Very simple. When you have a sweat, increased salty kiss, nothing but a case of cystic fibrosis. So always try to use your special senses to find out the Diagnosis. I am not here to talk about again spirometry or impulse oscillometry. Right now, we have so many people, so many new people are coming in Tamil Nadu who are very interested doing this spirometry or impulse oscillometry. But in the next 40 to 50 minutes, let me try to decode how clinically in your clinic within 5 to 10 minutes, either you can rule in or rule out asthma, whether the child will benefit from inhaler therapy or the child will not benefit from inhaler therapy. That is what we are going to discuss. I repeat, a simple clinical application of your basics. Okay. So, what are all the symptoms that suggest asthma? What are all the three symptoms suggest asthma? The answer is very simple. It doesn't mean that all asthma will present with wheeze, and not all wheeze is due to asthma. So, asthma usually presents with predominant cough, breathlessness, and noisy breathing. To any mother, noisy breathing is wheezing unless otherwise proved. And remember, it is not with these three symptoms, you need to form a pattern. And if this pattern confirms asthma, then reversibility of these symptoms with the bronchodilator confirms your diagnosis. So, when any child who enters your clinic with a recurrent cough, recurrent breathlessness, recurrent noisy breathing, responding to your bronchodilator are more in favor of asthma. So right now, I have three symptoms. There are n number of conditions in pediatrics that can have these three symptoms: breathlessness, cough, and noisy breathing. But how I need to make a permutation and combination of these breathlessness, cough, and noisy breathing to make a diagnosis of asthma. That is what my goal is clinically. I repeat. Right. So, for any person, whether he is a pediatrician or MBBS postgraduate, you need to know your basics. It is very, very easy to apply your symptoms with respect to your findings or with respect to your anatomy in your respiratory system. Starting from you all know that majority of you are aware of the fact that anything above the glottis is called as upper airway, anything below the glottis is called lower airway. But to me, I have a separate functional classification to teach my undergraduates and postgraduates. What is this upper airway, middle airway, lower airway, pleura? You must be wondered why this person is adding something new called middle airway. What is this middle airway? The answer is very simple. This upper airway, middle airway, lower airway, pleura behaves very peculiarly in producing the respective symptoms. So, based on those respective symptoms, you can easily decode yourself to the site of pathology. So, what is this? Upper airway means it starts from your nose, it travels through your nasopharynx and it ends in your glottis. So, what might be the pathology? The answer is very simple. When upper airway is getting blocked, when nose is getting blocked, you have a noisy breathing called stutter. When your nasopharynx is getting blocked, you have a symptom called snoring. And when your larynx is getting blocked, you have stridor. So the predominant manifestation of upper airway is noisy breathing. And it will be very, very easy for you to identify. Is it possible to differentiate between a stutter, snoring, and stridor? The answer is very simple. During your stridor is present during both during sleep as well as in awake state, whereas your stutter and snoring predominantly present during whenever you go for sleeping mode. So, what does it mean? The answer is very simple. When the mother's predominant complaint is my child is having noisy breathing, means it unless otherwise proved there is some block in your upper airway, stutter, snoring, stridor. The mother can say so many things. My son is having fever, my son is having noisy breathing, my son is having cough, my son is having breathlessness. But you need to pick up, you need to ask the mother, what is the predominant complaint? The predominant complaint with respect to upper airway is noisy breathing, stutter, snoring, stridor. Right. Then what do you mean by that middle airway? Middle airway is nothing but your trachea and bronchus. What does this trachea and bronchus contain? Majority of your cough receptors are present in trachea and bronchus. So the predominant complaint will be whenever there is any pathology is in trachea or bronchus, the predominant pathology will be cough because cough receptors are more in trachea, cough receptors are more in your bronchus. So when mother says that cough is the predominant complaint rather than noisy breathing, it means that you are dealing with a case of either tracheitis or you are dealing with a case of bronchitis. Most common cause for reversible recurrent bronchitis is your asthma or wheeze. And again, when cough is the predominant complaint, cough with the stridor indicates there is a tracheal pathology. Cough with the wheeze indicates you have a bronchial pathology. Again, it's very, very easy to decode. Then lower airway. Lower airway means what? It involves your alveoli and interstitium. Alveoli and interstitium is the place where gas exchange occurs. So whenever you have a problem involving your alveoli or interstitium, what will happen? Gas exchange will be gone. When gas exchange is gone, invariably it leads to hypoxia. Hypoxia in turn leads to tachypnea. Tachypnea in turn leads to breathlessness. So when mother says breathlessness as a predominant complaint rather than cough, the problem is in the lower airway involving your alveoli or interstitium. The most common cause involving your alveoli is consolidation, presenting with the fast breathlessness, nothing but pneumonia. The most common pathology that associated with the interstitium is interstitial lung disease, usually subacute afebrile breathlessness. The answer is very simple. Do you get cough as a predominant complaint in lower airway involving alveoli or interstitium? No. Alveoli and interstitium contain sparse cough receptors as a result of which cough will not be the predominant complaint when anything involves your alveoli and interstitium. Instead, tachypnea and breathlessness without cough. Right. And remember, upper airway usually associated with only your stridor associated with suprasternal retractions. Your trachea and bronchus, tracheal pathology associated with sternal retraction and bronchial pathology associated with the subcostal retractions, whereas alveoli and interstitium usually involved with the intercostal retractions. And what about pleura? The answer is very simple. Either your parietal and visceral pleura can rub against each other, can lead to lateral chest pain, or something gets accumulated in your pleura, either water or air. Either it is a pneumothorax or it is a pleural effusion. Based on the extent of this pleural effusion or pneumothorax, you will get breathlessness. So, what a first year postgraduate or what a final MBBS graduate need to know based on this anatomy or in this slide. Whenever mother is brought with predominant noisy breathing, the pathology is in nose, nasopharynx, larynx. When mother brought her child with cough as a predominant complaint, the problem is in trachea and bronchus. When mother brought her child with tachypnea and breathlessness as a predominant complaint, you are dealing with the alveoli or interstitium. When mother brought with chest pain to start with and then became breathlessness more in favor of a pleural pathology. This is what you need to know in your practice. When the mother starts to say something, listen to the first word. The first word indicates the site of pathology. Dot. Rest of the things, please do not hear. The first thing, the first verb, the first noun that the mother uses indicates the site of pathology. And these are all the things that the mother will exhibit. One is noisy breathing, second one is cough, third one is breathlessness, fourth one is chest pain followed by breathlessness. So the answer is very simple. You can directly go to the site of pathology and think about the corresponding etiology. Okay, right. Then So now I have, one second. Now I have either symptom mimicker. What are all the symptom mimickers? I told you cough, noisy breathing, breathlessness, so many things. Sound can be due to stutter, snoring, stridor, grunting. As I told you already, all mothers will say any noisy breathing would be attributed to wheeze. And remember, we have so many cases of cough dominant asthma. The asthma manifestation is only cough, dry cough, nocturnal cough, seasonal cough, trigger induced cough, everything, and that cough responds to bronchodilator. But remember, and you must be thinking in terms of starting an inhaler. But remember, dry cough can also be produced by pertussis, foreign body, mycoplasma, whereas the wet cough, along with the wheeze mimicker, can be produced by protracted bacterial bronchitis. Wheeze can be due to airway malicias. When you have a child with the wheeze from the early onset, think about airway malacia, not responding or worsening with bronchodilator. Sudden onset wheeze in pediatrics, which is not responding. Any first episode wheeze in pediatrics not responding to SABA is foreign body unless otherwise proved. And any wheeze which doesn't settle after a viral infection, most in favor of a post-infectious bronchiolitis obliterans. Congestive cardiac failure presenting as wheeze in pediatric age group is unlikely unlike in adults. What are all the breathlessness mimicker? Again, PO, PIBO, and ILD, can congestive cardiac failure, all can present with breathlessness. Okay, which will confuse you whether you are dealing with a case of asthma or not. Chest pain mimickers, generalized body pain. So many children are coming with a generalized body pain, particularly chest pain, with an underlying vitamin D deficiency. A TB pleurisy, chest pain. Any functional disorders can present with chest pain. So when you say cough, breathlessness, chest pain, responding to your bronchodilator or not responding to bronchodilator, these are all the symptoms that come to your mind, and these are all the differential diagnosis that comes to your mind. But but see, it looks very odd. Look, it looks very odd to remember each and every point in this. But remember, do not worry, my dear friends. Do not worry. The next two slides are going to be very, very helpful to find out when to start inhaler and when not to start inhaler. So let me go to my next slide. Pattern recognition. What is asthma? You need to know. What is not a case of asthma? You need to know. What do you mean by asthma? Remember, a recurrent cough, breathlessness, responding to bronchodilator. That is easy to say. But to me, majority of children, majority of mothers, majority of postgraduates will say there is a response to bronchodilator. Remember, response to bronchodilator is always a placebo. Whenever you do something, mother will say, yes, sir, relatively good benefits, sir. Plus, please do not listen to it. To me, when I diagnose asthma, I have the first and foremost complaint that I will expect from the mother is nocturnal cough. Nocturnal cough between 12 a.m. to 4 a.m. should be asthma unless otherwise proved, because there is an associated diurnal bronchoconstriction during that time. So whenever you have an associated atopy along with that diurnal variation, there will be definitely nocturnal cough. I will not diagnose any patient if there is no nocturnal cough between 12 to 4 a.m. So to me, when I diagnose asthma, the first and foremost thing that I will ask is cough between 12 to 4 a.m. That too dry cough. Wet cough can never be asthma. Point number one, nocturnal dry cough. It doesn't mean that the child will not be having cough during daytime. Yes, cough will be there during daytime. Even in pertussis also you will have cough during daytime. But the only cough that disturbs your sleep between 12 a.m. and 5 a.m. in morning is asthma unless otherwise proved, I bet. It is not pertussis, it is not cystic fibrosis, it is not PCD. The cough that disturbs your sleep between deep sleep between 12 a.m. to 4 a.m. The one and only cough is asthmatic cough or wheezy cough. And remember, asthma is a disease of inflammation and it is often trigger induced. So, what are all the trigger? Exercise. Whenever you walk, whenever you climb, whenever you play, you will get cough. And remember, laugh induced cough is so classical of asthma. Doctor, whenever my child laughs, she coughs, ends up in coughing, doctor. You are dealing with a case of asthma, emotion induced cough, laugh induced cough is asthma unless otherwise proved. So, environment, some trigger might not be good for your child. The child is going to that place only in that place, going to that place aggravates your child's cough. It could be either due to hypersensitive pneumonitis or it could be due to asthma. Each and every season, my husband is torturing me with this dry cough, sir. Why it is due to? My child is also having the same thing. Seasonal bronchitis or seasonal severe dry cough lasting for more than 10 days is these unless otherwise proved. Okay. Very, very rarely, only less than 10% of children will have food as a trigger. Very, very less. Less than 10% of children will have food as a trigger. And finally, coming to your own point. What is that response to bronchodilator? So many times I will be wondering there are symptoms suggestive of asthma, but why there is no nocturnal cough? Why classical symptoms are not there? Invariably, they would have been treated with either montelukast or oral salbutamol. So bronchodilator doesn't mean that it has to be given through nebulizer. So many times bronchodilators are given through IV, IM, oral. Majority of us, even though we speak a lot, every one of us are lighting salbutamol serum. It doesn't mean that people may say in an auditorium, we are not supposed to prescribe oral bronchodilator. For each and every kuti chota chota wheezy cough, how can you prescribe a inhaled bronchodilator? Not possible. So when you have a cough which is not fitting into asthma, but you are thinking in terms of asthma, just ask whether the child is on daily montelukast, which produces partial response, whether the child is on daily SABA. Okay. And again, steroids in any form. IM dexamethasone, IV dexamethasone, oral betamethasone, still it exists. Believe me, still exists. Okay. And it works too. Okay. Then age. Lesser the age, unlikely be due to asthma. I repeat, lesser the age group, unlikely be due to asthma. And finally, in physical examination, when you diagnose asthma, your growth chart should be proper. Weight pakka, height pakka. When anthropometry, whether the weight is affected or height is affected, my diagnosis is 100% not asthma. Only when my percentile chart fits into the 50th centile, both weight, height, and BMI, my diagnosis will be asthma, or else I will be thinking something else before starting inhaler therapy. Clubbing is not a manifestation of asthma. And remember, asthma usually presents with the chest indrawing and subcostal retraction initially, but later on you can get suprasternal, subcostal retraction based on the severity. A mild asthma usually have a predominant subcostal retraction rather than suprasternal and sternal retractions. And remember, majority of asthma, you all know wheeze is an expiratory component, but at times you can have small early inspiratory crackles because of the small collapse in the smaller airways. So remember, very simple, nocturnal, dry cough, laugh induced cough, play induced cough, recurrent seasonal cough responding to bronchodilator in a well thriving child with the onset of more than 1 year must be asthma unless otherwise proved. Okay, right. Then comes what is not asthma. Even when one of these points is present in the history, I repeat, even when one of these points is present in the history, even when one of these findings are present in physical examination, I will not be starting inhaler therapy in this child. When asthma starts early in the age less than 1 year, but at times it does happens. Usually they start with the RSV bronchiolitis, then episodic wheezer, then multi-trigger wheezer. But majority of the times try to diagnose asthma in older children rather than younger children. Recurrent high grade fever can unlikely be due to asthma. Then people must be asking an episodic wheezer usually starts with a viral fever. So ask one simple complaint. After fourth day of fever, after fourth day of admission, because people, children will be receiving nebulization, children will be receiving IV antibiotics too. But you need to ask one simple question. By about third day or fourth day, which one is predominant? Everything starts with fever. Everything starts with cough and breathlessness. When mother says, sir, by about third day or fourth day, fever becomes low grade and cough becomes more. So fever goes, cough comes. Again, you are dealing with a case of airway asthma and not PCD and not CF and not PID. Asthma is always trigger induced. Yes, sudden onset cough in pediatrics, sudden onset wheeze in pediatrics, you all know, must be foreign body unless otherwise proved. Literally, I have not seen a case of wet cough in asthma. Might be in older children, might be in adults. But to me, a wet cough with a little bit of asthma like qualification must be primary ciliary dyskinesia unless otherwise proved. You would have heard so many things: middle lobe syndrome, right middle lobe syndrome, Brock syndrome. That middle lobe infiltrates could be due to poorly controlled asthma, could be due to TB. But remember, my dear friends, in X-ray you will have bilateral hyperinflation. When X-ray shows a middle lobe infiltrate silhouetting with your heart shadow, you are dealing with a case of primary ciliary dyskinesia. You must be wondering whether this primary ciliary dyskinesia is there in our country. The answer is yes. Your primary ciliary dyskinesia is going to surpass cystic fibrosis, surpass primary immunodeficiency. Please write this in your notes. In the past 2 months alone, in my clinic as well as in my institute, we have around 5 primary ciliary dyskinesias. Majority of those primary ciliary dyskinesias have some asthma qualifiers. Majority or almost all have middle lobe infiltrates. So a non-resolving middle lobe infiltrates in a child on high dose inhaled corticosteroids and formoterol or salmoterol is PCD unless otherwise proved. It is there in our country because our country has 150 crore population. You mean anything? Inborn errors of immunity, yes. Inborn errors of metabolism, yes. PCD, yes. CF, yes. PID, yes, 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 yes. The answer is 150 crore population. Expect a very most uncommon things that you read in your Nelson is revolving in and around you because it is India, because it is 150 crore population. The answer is very simple. So PCD is there in our community, right? And remember, so wet cough could be due to so many things. To me, difficult to differentiate between other mimickers and asthma is primary ciliary dyskinesia because here you don't have that kind of bronchiectasis in all cases, that kind of high grade fever that you expect in CF or PAD. This is a great mimicker for asthma and it is going to be a challenge. But remember, take my words, middle lobe infiltrates, not responding to, let me say, 400 budesonide plus formoterol or salmeterol. It is PCD unless otherwise proved. You must be reading in your books. Your discharge should be there. Rhinorrhea should be there. No, Picard score will be helpful, but that to me, after spending a decade in my institute, PCD is a spectrum. Majority, almost all of them have middle lobe infiltrates. All of them have some asthma qualifiers. Rhinorrhea may or may not be there. That rhinorrhea, most often they would have attributed to allergic rhinitis. But allergic rhinitis, you'll have vertical itching of nose. along with the morning sneezing. But remember, in PCD, you will not be having that sneezing and vertical itching. Rather, you will have a perennial rhinorrhea. And remember, and please remind, in our country, I have seen very handful cases of proven PCD with atoria. Nielsen says that the one which differentiates between cystic fibrosis and asthma and primary ciliary dyskinesia is ear discharge. No. Out of my 25 cases, only 4 cases has got rhinorrhea. Rest of the case doesn't have that rhinorrhea. Wet cough, middle lobe infiltrate, not responding your standard treatment protocol with idosteroids is PCD unless otherwise proved. And breathlessness. I repeat, you can have cough plus or minus breathlessness because asthma is a disease of bronchitis. Bronchus contains cough. So cough should be there. When you have cough alone, you can diagnose asthma even when you don't have wheeze, even when you don't have breathlessness. Previously, they didn't accept the term cough dominant asthma, but it comes into place right now. But do not diagnose the reverse one. What is that? So, what I mean, isolated dry cough, you can diagnose asthma, but isolated breathlessness can never be asthma because asthma is a disease of bronchitis. Bronchitis means you need to have cough, right? So breathlessness without cough must be due to cardiac, must be due to hematologic, or pulmonary must be due to an interstitial pathology as we discussed in our third slide. And remember, to me, personally to me, I will not diagnose asthma without nocturnal cough. I will not diagnose. I am very much biased to that particular symptom, to be very frank. Physical examination, clubbing rules out, failure to thrive rules out, predominant suprasternal retractions rules out, and as I told you already, persistent any BHI is accepted one. Rest of the things, even a single persistent lung shadows, particularly middle lobe, do not think about that middle lobe syndrome, Brach syndrome as due to asthma. It is not, so it's PCD. Or if there is failure to thrive or recent weight loss, think in terms of TB because you are living in India, right? So these two slides, my dear friends, when to diagnose, when not to diagnose is more than enough for my first year postgraduates or a common pediatrician to start or not to start inhalers. Yes, spirometry, you have a obstructive pattern, you have a scalloping, you have a reversibility. Usually we do after 6 years. Okay. You can try even up to 4 years. And then now many people, our new pediatric pulmonologists are started doing impulse oscillometry, R5, A5, A10, AX, so many things. But it is for pediatric pulmonologists. But for pediatricians, what to be known? So the top, what are all the top musculators you have? So upper respiratory tract, people most often allergic rhinitis and chronic sinusitis due to either PCD or adenoid will have a postnasal drip. This postnasal drip will produce cough after you go for sleep. But definitely, again, this postnasal drip occurs as a result of allergic rhinitis or sinusitis, unlikely to produce cough between 12 to 4 a.m. Again, middle respiratory tract means trachea and bronchus. You all know any child with the wheeze from birth or immediately after early infantile period is airway malicious. But in my practice, majority of cough syndromes that is started purely based on inhalers started purely based on cough as a predominant complaint fits into pertussis. I have told just now that cough alone can be a manifestation of asthma. But please do not miss pertussis. Pertussis is there in our community. Why? The answer is very simple. By 10 years, the government is giving TD vaccine and not Tdap. So you are missing pertussis component. Second point, up to 5 years, your parents are absolutely cared about you. But by about 10 years, they are concentrated on HPV vaccine rather than Tdap. Okay. So, one side in government, they are not considering pertussis vaccine at 10 years. On the other side, in private also, still they are giving TD. And you have waning immunity. And pertussis is dry cough for about weeks to months together. Please do not forget pertussis because before starting your inhaler therapy, in the recent GINA, pertussis has been added as a differential diagnosis for asthma. Pertussis is there? The answer is yes, boss. The answer is yes. Yes, to how to diagnose? Here comes some of the slides. Vocal cord dysfunction, stridor, adolescent, yes, theoretically it's good, but in my personal 15 years of experience, only 2 to 3 cases I have seen that confused with asthma. Very, very unusual. Maybe in my cohort, either in my clinic or in my Mayurmadi ICH, but definitely, I don't know, vocal cord dysfunction is not that common as compared to other places, and it causes confusion with asthma. Foreign body aspiration, okay, lower respiratory rate. These are all the things I had discussed just now. Okay. So acute wheeze could be due to bronchiolitis, foreign body. Remember, the only when it is often okay, a very good people who are good at antibiotics usually they have a saying: whenever you have a wheeze, please do not start antibiotic. Wheeze is equal to viral. Literally, it rules out antibiotic usage. But the only bacterial infection that produces wheeze is mycoplasma. But viral infection usually will have URI, but mycoplasma will not have. Chronic wheeze, there are so many things, structural anomalies. These are all the things everyone knows. Functional abnormalities. I'm not going to read each and everything and going to bore you. Rather than let me go to some of the case scenarios that I had in my institute. And what are all the famous asthma mimickers? Infants, bronchiolitis, airway malacia, vascular rings, toddlers, foreign body. I have so many surfactant dysfunction mutation. After adenovirus, any persistent wheeze, you, me, everyone knows it is PIBO. Teenagers, inducible laryngeal obstruction, protracted, I repeat, apart from pertussis, protracted cough lasting for about 3 to 4 months can occur in mycoplasma, will occur in mycoplasma. Please do not start inhaler therapy because I told you cough alone can be a manifestation of asthma. Right. So, to start with, based on the symptom pattern that we analyzed right now, let us start one by one. Almost over 5 to 7 case scenarios. Let's have persistent wheeze since birth, reduced air entry, and worsening with the bronchodilator. So, what are all the red flags here? Asthma, okay, the child is on inhaled therapy. What are all the red flags? These cannot occur, asthma cannot occur in a child of since birth. It is unlikely to occur. But there is a reduced air entry. How a reduced air entry can occur? Even sometimes in asthma, you have a reduced air entry that is due to mucus plugs. You give a nebulizer, air entry will increase, the mucus plug will be cleared. And this child is worsened with bronchodilator. You can have a BHI in case of asthma, but here there is unilateral hyperinflation. So what is this? Is it due to mucus plug? But the red flag is since birth, unlikely. Is it due to a bronchomalacia? Could be. Yeah, it could be bronchomalacia. So this is not an asthma, not to say a fancy diagnosis. The answer is very simple. This child, 1 year old, had received treatment with inhaler for about 3 months, referred finally as a case of foreign body because there is a unilateral hyperinflation on the left side. But it is asthma. Why? Because it is not responding to bronchodilator, not responding to inhaled corticosteroids. It is persistent. This asthma is reversible and it cannot present from birth. So, what is this? A bronchogenic cyst compressing your left main bronchus, mimicking a foreign body, mimicking a V's also. The answer is simple. I'm not going to say you need to take a CECT test. The answer is simple. V is not responding to bronchodilator since birth. The answer is something else. Do not start inhaled corticosteroids. What is this? 3-month-old child treated as a case of bronchiolitis. I repeat, 3-month-old child treated as a case of bronchiolitis. Like this. Okay. And then each and every time the child goes, there was a fancy term used. What is that? Recurrent bronchiolitis. But there is an intense cough. What is that cough? Intense metallic cough. The mother says the response is partial. See how to know. Each and every mother will say, after nebulization, the child has been doing well. Each and every mother will say. But to me, I will teach my students, ask one question. Is there any dramatic response, at least for time being? After nebulization, is there any dramatic response, at least which lasts for about 20 to 30 minutes? If the mother is thinking the diagnosis is not asthma. Okay. And remember, the mother says whenever the child flexes her neck, the sound increases. Is it asthma? The answer is no. I could play the video, metallic cough. So what is this? Pulsatile tracheomalacia. Again, what is this? You could see a double aortic arch in this case. This child has been treated as a case of recurrent bronchiolitis. What is the red flag? Partial response. What is the red flag? Metallic cough. Metallic cough will not occur in asthma. You can have a dry cough. Metallic cough means your anterior trachea touches or kisses your posterior trachea. So the kal metallic cough is tracheomalacia unless otherwise proved. Early onset again confirms the diagnosis with or without a vascular ring. Right. The third one. So this child was admitted thrice in different floors. Okay. There was a proper documentation. In one of the admission, they mentioned V's. In one of the admission, they mentioned Strider. How could you have a Strider and V's in the same child? At once, the child was treated as group. In one another ward, in the 2 weeks after admission, the child was discharged, readmitted, and here they documented V's and they started SABA. So they manage it as group, they manage it as V's. How can it be possible? The answer is very simple. When you have a groupie cough, the level of obstruction is in the trachea. When you have a V, the level of obstruction in the bronchus. So combine both, which can produce these things. Only a foreign body can produce these things. A foreign body in the trachea will produce metallic cough, croup-like sound. A foreign body in the bronchus will produce wheeze. So what is that? This is otherwise called a migratory foreign body. Look at this. When we do a bronchoscopy, the foreign body is moving inside the trachea as well as going and settling in the bronchus. Luckily, for about 3 months, the foreign body is still migratory, maybe due to good planetary position of that child or due to their parents' planetary position. Okay. Now, here comes almost once in 2 months. I have these cases across age group, starting from day 5 to day to 15 years of age. The pattern is one and the simple. Almost all these child, look at this, the one on the second, the one on the third, early infants. The one on the left boy, the other on the right girl. All of them had received inhaled corticosteroids. Some children were extensively worked up with FOB also. But the one pattern, common thing that in each and every child is this. Look at this boy. Coughing, 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 coughing. Redness of eyes. Redness of eyes. Tears from eyes. Again, this child coughing, coughing, coughing without any breathing in between a little bit of redness of face, not compared to the previous. Look at this again, coughing like anything, coughing like anything, without any intervening breathing. And finally, this child coughing, redness of eyes and tears from face. So it doesn't mean that you need to do a PCR for pertussis. No, not needed. Book says paroxysmal cough, post-acute vomiting, and inspiratory whoop. When one of these things are present, your diagnosis is pertussis. To me, any child with cough without any breathe in between, coughing, 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 coughing without any breathe in between, that is called paroxysmal. And compared to that post-acute vomiting, compared to that inspiratory whoop, that is what the book says. To me, any child, adolescent, peri-adolescent, cough down, before diagnosing cough dominant asthma, I will ask one simple question. Whether your child is developing tears from eyes and redness of face. If it is so, don't worry, my dear boys and girls. It is nothing but pertussis, pertussis, pertussis. Wet cough mimicker is PCD. Dry cough mimicker for asthma is pertussis unless otherwise proved. I bet. Just ask when you want to start inhaler therapy for a dry cough, which has been there for 2 to 3 months. Because it doesn't mean that when you start azithromycin, it will respond. It is not so. Even when you start your macrolide, you need to start within the first week of illness. If it is not so, it is not going to give any benefit to the child, but it may prevent pertussis to spread to others. That's all. So remember, pertussis is there across age groups, starting the last case that we had referred from the southern parts of Tamil Nadu is a 25-day-old baby, extensively worked up with the HRCT, extensively worked up with the FOB also, but turned out to be pertussis. Okay, right. So pertussis is a great mimicker. Redness of face and tears from eyes is pertussis unless otherwise proved. All cases of so-called cough dominant asthma, you need to suspect pertussis. Ask these simple questions. That's all. Right. And what is this? 8-year-old cough 3 months, no constitutional symptoms, non-productive cough. Always dry cough means you are on a safer side. Dry cough, either a post-viral cough or a wheezy cough or a foreign body or a habit cough or an environmental smoking induced cough. Majority of these dry cough will settle on its own. But when it is wet cough, less than 2 weeks, don't worry. 2 to 4 weeks with URI is sinusitis. More than 4 weeks, PBB, protracted bacterial bronchitis. But majority of my cases, so-called PBB, are turning out to be PCDs right now. But leave alone that. Wet cough is not asthma. That's all I want to convey. So 8-year-old cough 3 months, no constitutional symptoms, non-productive cough, chest clear, a course of amoxicillin is over, azithromycin is over, anti-reflex is over, trial bronchodilator is over. Do I need to? So I'm sorry. Cannot play media. Cut copy paste was done something wrong. So whenever you have a dry honking cough, dry honking coughing from here, dry honking coughing from here is usually habit cough. When you distract, when you threaten them that you will put some injection. Okay, definitely. When will you ask them to count for about a minute or two, and when will you say you will be gifted if you don't get cough for the next 2 to 3 minutes means they will stop coughing. Again, what is this? It is a case of habit cough. Habit cough is on the rise. I repeat. So when everyone else is unhappy, but my child is happily coughing, that is what is that? Habit cough or psychogenic cough, literally absent during. It is always dry cough, always harases from here, always absent during sleep. Right? And what is this? So this doesn't belong to me. taken from internet. What is this? 5-year-old, cough 5 months, no cough at night, constitutional symptom, X-ray is normal, no response. After it was revealed she used racial slurs. At a food festival in Miami earlier this week, Paula seemed like her old self, climbing on the back of fellow celebrity chef Robert Irvine. Ride him, cowgirl. So remember, when you have, apart from cough, when you have shrugging of shoulders, some vocal tics, and you do some other gestures often along with cough, it is usually not habit cough. It can be a manifestation of a tic disorder. So apart from verbal tick, your vocal tick, one of the vocal tick is cough, which is also again confused with asthma. Okay, what is this? This child is a known case of asthma on inhaled corticosteroids, completed 3 months of treatment. Now she came to me. The present complaint is no significant cough, no systemic manifestations, and height and weight well preserved ABG normal study. But look at this. அடிக்கடி மூச்சு வாங்கும் சார் இந்த மாதிரி ஆனா இப்ப பரவாயில்ல சரியாயிடுச்சு. What is this? What is this? This is not an hyperventilation syndrome. I can say this condition sits just below hyperventilation syndrome. What is that? This is nothing but sighing dyspnea. This is nothing but sighing dyspnea. Again, what is the predominant complaint? So here everything else is normal. The child feels that she's not happy with the air that goes inside. She feels empty. So she wants to inhale more and more. Does this child requires a bronchodilator? That this breathlessness is wheeze? No. Asthma means cough plus breathlessness. Here there is no cough, but there is only breathlessness. But everything else is fine. This is called sighing dyspnea. Particularly, to my knowledge, after COVID, after the child has been locked to rooms, houses, I have been seeing many cases of girl children developing this sighing dyspnea, wrongly classified as breathlessness due to asthma and started on inhaled corticosteroids. A happy child with taking a deep breath consciously and deep breath out is called sighing dyspnea. Normally, you and me will also do that side to remove that small collapse in the lung. But usually that occurs once in an hour. If that rapid breathing, deep breathing, which occurs for each and every minute, then comes sighing dyspnea. Right. So these are all the functional respiratory disorders. Right. What is this? A call over was given. The child was sick. I repeat, a call over was given. The child was sick. The child is having wheeze. The child is having wheeze. So what is the finding? I repeat, the child is having wheeze, not responding to bronchodilator. What is this? The answer is, look at this. Is there any retractions? If it is an asthma, the child should be coughing by the time. No. If it is asthma, the child would have been developed some retractions, but there is no retractions. So what is this? Compared to the extent of tachypnea, if your child doesn't have cough, doesn't have retractions, it is, what is this? It is, look at the ABG pH 6.7, a case of acidosis, Kussmaul breathing. You might be wondering whether you could hear wheeze in Kussmaul breathing. The answer is yes. At times, when your tidal volume, when your lung wants to expire more acid as CO2, at times because of turbulence of air, you can have wheeze in diabetic ketoacidosis or any Kussmaul breathing too. But remember, there is no cough, there is no retraction. This is Kussmaul breathing. That is the clue. Okay, this child presented in many forums came to us as a case of difficult asthma, started on budesonide and formoterol 200 BD and sent to our institute. Sent to our institute. The mother was totally unhappy. Okay, look at this. ஓடு நல்லா ஓடிட்டு வா போ பத்தாது நல்லா பத்தாது பாஸ் இவ்வளவுதானா Yes, is it wheeze? Yes, exercise induced sound is there. Asthma is exercise induced. But where you will get that retractions, where you will get that retraction, as I told you already, the retractions are predominantly in the subcostal area. Here, the retractions are in the suprasternal area, and he has an inspiratory sound rather than expiratory sound. So, suprasternal retraction, inspiratory sound. This is a case of congenital subglottic stenosis presented at 4 years of age. I'm not talking about the congenital. I have found out congenital subglottic stenosis at 4 years of age. The answer is very simple. How can you have an inspiratory predominant sound? How can you have a suprasternal retractions in a child with asthma? Asthma means subcostal. Asthma means expiratory, right? So pattern recognition matters. This case, a peculiar case. So what the mother says, if there are some Tamil speaking audience, let me try to play the video as told by the mother.
சளி இருமல் பிரச்சனை இருக்குது வாமிட்டு வரும் அதே சாப்பிட்டாலோ இல்லை தண்ணி சாப்பிட்டாலோ சாப்பாடு சாப்பிடும்போது அவனுக்கு வந்து இறப்பு மாதிரி வாங்கும் அது ரிட்டர்ன் வந்தால் தான் அவனுக்கு சரியாகிற மாதிரி இருக்கும் இல்லைனாக்கா அவனுக்கு சரியாகாது கொஞ்சம் நேரம் இஷ்ட மாதிரியே இருக்கும் அந்த சாப்பாடு வெளியே வரும்போது நைட்டில் தூக்கத்துலேயும் அதே மாதிரி சாப்பிட்டு படுத்தாங்க கொஞ்ச நேரம் நல்லா ஜோராக தூங்குவான் தூங்கும்போது அவனுக்கு மூக்குலையும் வாயிலையும் இரும்பின உடனே குபீர்னு வந்துடும் மூக்குலையும் வந்துடும் வாயிலையும் வந்துடும் அப்படியே திணறது மாதிரி அவனுக்கு ஆகிடும் தொடச்சி விட்டு திருப்பின தூங்குறான்னு சொல்லிட்டு தூங்கிடுவான் திருப்பினும் அதே மாதிரி ஒரு 10 நிமிஷம் 20 நிமிஷம் தூங்குவான் அப்படியே ரிட்டர்ன் வந்துடும் திருப்பினும் இதே மாதிரி அவனுக்கு வயிற்றுல இருக்கிறது மொத்தமும் வந்தாலும் கொஞ்சம் தூங்குவான்.
You could understand what the mother says. The answer is simple. My postgraduate, third year postgraduate says, sir, you told nocturnal cough, sir. The child is having nocturnal cough. Okay. Sir, you told GRD can be a manifestation or an association as a cause. The child is coughing at night and the child is having vomiting. So, my diagnosis is asthma with severe GRD. Okay, but what is the one that hits here? Birth weight is 3 kgs, present weight is 9 kgs. And again, anthropometry doesn't fit into asthma. So what is this? So he wanted to take a barium swallow, removed with this thing. So what is that? Echalacia cardia, mimicking as wheeze. What is the simple clinical point? Weight is not maintained. For a 4-year-old, how can the child can have a 9 kgs? He lost everything in vomiting. Okay, and achalasia cardia mimicking as nocturnal cough, right? And mimics wheeze. You just go and refer. There are so many similar case reports are there. Again, the simple clue is weight is not maintained. That's all, boss. Okay. And finally, I don't know whether I can play this video or not. So this is free exercise. This is post exercise. So look at this. Supraglottic approximation during inspiration. Nothing but this is called inducible laryngeal obstruction. When the same thing occurs with respect to vocal cord, it is called as vocal cord dysfunction. The answer is very simple. Predominant inspiratory sound is unlikely be due to asthma. Why do you bother about the vocal cord dysfunction and all? They are all predominant inspiratory sound rather than expiratory sound. That's all. Okay. This is somewhat fascinating and gave me so many insight into this disease. 7-year-old girl, recurrent wheeze. I even personally documented wheeze. Steroid non-responsive. Apart from the two documented stridor, is it foreign body? No. No constitutional symptoms. So what it could be? Wheeze is documented, steroid non-responsive, sometimes stridor. We have some cases of recurrent group, allergic group manifesting with the stridor and spasmodic cough in a known asthmatic child, particularly 2 to 5 years. But this child is 7 years old. Or is there any extraluminal compression causing both trachea and the bronchus? What is this actually? What investigation do I need to do? What artificial platform I need to do? FOB, spirometry, swallowing study, CECT? No. God's best natural intelligent platform is your eyes. Look at this. The child is able to touch the tip of the tongue by her tip of the nose by her tongue. Gorlin sign, kyphoscoliosis, hypermobility, extensible joint. What is that? Skin. What is this? Yes, it is Ehlers-Danlos syndrome. You would be wondering how Ehlers-Danlos syndrome manifests as a difficult asthma. I missed in the first 3 instances. Only in the fourth instance, we found out this. Why? Because Ehlers-Danlos syndrome is a disease of collagen vascular disorder, abnormal weak collagen. So bronchomalacia. So you have these tracheomalacia. So you have stridor. The answer is simple. Look at this again, a simple physical examination. We stopped inhaled corticosteroids in this child. Again, finally, what I want to infer to each and every audience here, 12-year-old asthma qualifiers plus bronchodilator reversibility is documented 14%, but partial response to inhaled corticosteroids. On intranasal steroids too, because the mother says rhinorrhea on budesonide, 400 plus formoterol plus fluticasone. But remember, my dear friends, you need to have only BHI. Middle lobe infiltrate is there. This is a case of, again, primary ciliary dyskinesia. The rhinorrhea is attributed to allergic rhinitis. Here, there is no vertical itching. Here, there is no morning seizing. This is a variant of primary ciliary dyskinesia, a greatest asthma mimicker in the current days. Right? Okay. So, what to do in case of no response to standard management asthma fails? Simple, a carry home message. Finally, sudden onset differential RN3, foreign body, monophonic wheeze since early infancy, bronchomalacia, dry honking cough, absent during sleep, habit cough, adolescent with stridor or wheeze, more suprasternal retraction, vocal cord dysfunction, wet cough, more than 4 weeks. Usually, there is one fancy word called protracted bacterial bronchitis. Leave it. Okay. Recurrent febrile wheeze with the clubbing and failure to thrive, cystic fibrosis is not uncommon. Not uncommon. Okay. Please, whenever any child with wet cough, failure to thrive, clubbing, weight affected, growth affected, with asthma, some asthma qualifiers is CF. But we don't find that kind of failure to thrive or clubbing in children with TCs. Breathlessness more than cough is either PIBO or an ILT. Persistent wheeze past 3 months, PIBO. Okay, that's all. So it's very easy to diagnose a case of asthma. It's very easy to rule out asthma. But sometimes asthma can coexist with a CF, with a PCD, with a foreign body. It can have. So it's difficult to find out an asthma within an atypical visa. That is how you need to. So first, so if you are a pediatrician, Okay, asthma typical we start ICS. Okay, if it falls into second and third category, kindly refer and relax yourself. It's our headache to do all those things. Okay, so whenever you have recurrent noisy breathing, cough, and breathlessness, it doesn't mean that you will benefit from inhalers. It is not like your Aladdin that comes out of your inhaler and solves all your problem of noisy breathing, cough, and breathlessness. It should be asthma. Then only it will respond to your inhalers. So, younger the age, don't diagnose asthma. Preterm can have BPD, bronchodilator worsening, airway Malaysia, cyanosis and clubbing literally rules out asthma. Diurnal variation is typical of asthma. Apart from that, the environment, emotion, exercise. Among this, to me, the most pet question will be laugh-induced cough is wheeze. Failure to thrive again unlikely be due to asthma. So finally, cough may whisper, noisy breathing may confuse, breathlessness may alarm you, but we call it asthma only when these sounds dance in a variable reversible pattern and quieten with a bronchodilator. Okay, with this, I'm ending my presentation. Thanks for your opportunity, my dear Manju. Thanks for your patient listening, my dear friends, teachers, as well as postgraduates. Over.
You
From
can stop sharing, sir. I mean,
okay, right.
you can stop presenting.
Bus. Stop now. Still 1 second. Now it's okay now.
Yeah.
Okay.
Sir, I've heard so many asthma mimics in the past. Never have been this descriptive, never have been this elaborate and so clear. I'm so thankful for you to spend this hour and above. It's almost 1.5 hours since the time we have started talking. It's amazing.
Thank
And
you.
thank you so much, sir. Thank you so much. I am so delighted listening to your entire talk. It's nothing but a pleasure. Oh, thank you. And make sure that you like and subscribe to my channel. I'll try and bring as much as good content as possible. Pretty sure. Make sure that you post all your questions. Um, Me and Dr. Sharath Balaji, I'll convey all the questions to him and get the answers for all the questions what you post. Thank you and have a good day. Bye bye.